Welcome back to The Directors, a special segment of the Cancer Letter podcast. The Directors is sponsored by ASCO, the American Society of Clinical Oncology. This time, Yolanda Sanchez, Director of the University of New Mexico Comprehensive Cancer Center, and Kelvin Lee, Director of the Indiana University Simon Comprehensive Cancer Center, join the podcast. They talk about building the next generation of scientists and what it means to protect young researchers in an era of much uncertainty for academic research. In many ways, they conclude, a diverse ecosystem is the key to a resilient institution. With that, let's get started.
Well, Dr. Sanchez, Dr. Lee, thank you so much for joining us on The Directors, the podcast of the Cancer Letter, where the first question is always the same. And the first question is, what is keeping you up at nights as you're running your institutions, comprehensive cancer centers, in February 2026?
Well, thank you, Paul, for having us. It is quite a pleasure. We've heard wonderful things about this podcast. I think the thing that's keeping me up and has kept me up for the last 12 months really is the uncertainty. And I have to compliment all of our advocates, the AACI, AACR, American Cancer Society, all the patient advocates, and then all of our legislative and governmental supporters that have really sort of tamped down, especially the NIH, NIH funding issues. But really the concern continues to be the uncertainty going forward. I mean, I think that as cancer center directors, we are very used to a very structured way of how things are organized, how things are reported, how things are measured. And that's all changing on top of sort of the changing landscape for funding. And then the questions of, well, I mean, I don't think any of us want to go through that again. So then the questions are, how do we mitigate and prepare for that in case that happens again? So those are the things that really keep me up at night. It's that uncertainty, and how do we adjust for it? How do we plan for resiliency in the face of uncertainty? How do we manage all those things?
Yoli?
Thank you for having us as well. And I would like to echo Dr. Lee's gratefulness for all the advocates and everyone who stepped up during the past 12 to 13 months and keeping, right front and center the mission and the vision of the NCI and the cancer centers. And that is really to take care of the people that we serve. And so, we are a cancer center that's affiliated with a health system that has a safety net hospital. So we take care of everyone, regardless of what's in their wallet. And so our mission is to provide world-class, seamless integrated care driven through innovation and research and delivered with compassion to all New Mexicans. And you can imagine that then the challenges both on the clinical side and on the research side. And really, clinical research is clinical cancer care. And so what we have been doing is, I try to pull my hair out at night so that I can come back in the day and not have my people pull their hair out, so that I can come across as someone that is taking opinions and like Dr. Lee said, give us ideas of how to be resilient, because this is not the only time that we have been here. We had a recession in 2006 and 2008. We had another structural change in 2014, economic. Then we had COVID, and now we're here. So there is no perfect time for this job. So we just have to work together. And I'm really grateful that being a new director, that I had this community of directors that met every other week, and we really brainstormed and supported each other. And that's been great. That's, even though I'm up at night, I have a community that I can go to.
Mm-hmm, mm-hmm. Yeah, I'm just thinking out loud. A year ago, we all would be pulling our hair out over, oh my God, what is coming down the pike? But what came down the pike was not nearly as bad. And to some extent, that's the process you have described. But there's also a process that you haven't described, which is patients. We haven't heard from patients yet. Uh, what we need to, don't we?
Oh, for sure. And I actually do think that we have heard from patients. I actually think that the patients were the voice that all our government folks, all AACR, AACL, all our organizations, they were ultimately who everybody was listening to, and the impact of that. And so really hats off to them for stepping up and telling their stories and making it compelling for why cancer care, cancer research, cancer education are all important. But I think we have to continue that. And I think that one of the themes that had come out during the last year was, I think a lot of people, including perhaps some of our cancer patients, don't really realize how much advancement has happened because of cancer research over the last 20 years. And I take care of myeloma patients, and I can say that we've seen that in the last 5 years, that things that we would never have imagined possible 5 years ago are now standard of care. And looking another 5 years ahead, the things are remarkable. Our ability to communicate that, I think, is going to be incredibly important, and get that out to the public, get that out to our patients, get it out to all of our advocates, so they can also communicate the same message. But I think our patients have been tremendous supporters of what we're doing. We just need more of them.
That's where I was going.
Yeah.
Yola, have you been able to use them?
Yeah, so we have a lot of patients who have patient stories, and we have that is part of our portfolio of how we communicate with statewide on the importance of cancer research and the importance of a comprehensive cancer center in the state, which we are the only NCI designated cancer center in New Mexico. And we have shared those stories with AACI and others. And I think that in front of, the appropriations committees in the hearings, they were patient stories. And I think we organized around, and we have our community advisory boards that were ready to rise to the call to go to Washington and tell their stories.
Yeah. Well, I guess I'm kind of looking forward to the day when patients will be able to say, I brought my cancer center director to Washington,
Yes.
rather than the other way around. That's where I was coming from.
Yes.
So it's in a way, it's not like the centers using patients, but the patients using centers.
And I think the last year has actually opened that door. I don't think people had been thinking that way until over the last year. The advocacy has really ramped up. And now that whole point of, hey, somebody from Muncie should call me up and says, I'm visiting my senator. You want to come out, and come with me? Happy to do it.
Yeah, I'm going to kind of shift gears abruptly. Can we talk about site visits? And actually more, maybe even a little more broadly about renewals. And I think, Dr. Sanchez, you are going through one now. What's it like? Do you wish you had a site visit?
So thank you for that question. Like everything else that has happened in the last 13 months, this has been the season for the pivot, right? We have accommodated a new review process. And we are responding and rising to the challenge. I think site visits are important. And the reason for that is that you can't tell on paper, the presence of a cancer center to its catchment area. You can describe it, you can tell stories, but it's when you visit the cancer center. I have been at the Simons Cancer Center, so I know exactly, the impact and how people work together. And I think that's what you get from a site visit. how does the team work together and how do they serve the community through research, through education, through community engagement and patient care. So I do think site visits are important. Right now, we are in a process. We're waiting to hear how the process is going to roll out. I think once the process is established, future reviews are going to go more seamlessly.
Yeah, Dr. Lee, what's worrying you?
When I was way back when I did have hair and I hadn't pulled it all out,
I knew you were going there. I'm sorry.
I was told by a cancer center veteran that the CCSG renewal, and in particular the site visit, is kabuki theater. It is art, but it is very highly stylized art. And so now we don't have the kabuki theater anymore. We don't know what the stylized components are anymore. And I'll say, sort of selfishly, it's better you than me, because I think Yoli's point is we're going to discover how this whole review process goes. I think it's still evolving, and I think that the reviewers are evolving. So I think that we won't actually know what the actual kabuki theater looks like for, another 2 or 3 years, because everything is still moving. And even sort of the site visits, skinny site visits, no site visits, I think all that's still evolving. So I think that those are questions. And then sort of, one area that we've always asked is, there's now a focus on impact, right? But impact is in the beholder's eye, right? And so what does impact mean? How do we measure that in sort of a consistent way? Now that we aren't just counting beans, publications, grant funding, how do you actually measure impact and say impact in a population study is more or less than impact in a basic science area? And then how do we merge all that together in sort of figuring out the overall impact of a cancer center?
Mm-hmm. But actually, as far as the review, last time the three of us talked about it was at the AACI annual meeting, and all of us I was kind of blew my mind to hear that the reviews didn't go so badly.
That was good.
Reviewers have been so good.
That was very promising. And so and this is the thing again, resonates with the sort of what keeps me up at night. If that stays that way, that's great. If it somehow morphs into something else, or all of a sudden we can't get good reviewers, or that process changes, then we are back in sort of unknown territory. And that's, again, one of the areas that I think we'll have to see what happens over the next year in terms of the reviews, whether they stay consistently good, which was very promising to hear at AACI, or if they somehow are changing because of the mix of the reviewers or available reviewers, et cetera.
Yeah, I think it's going to be an evolving process, and it's going to take maybe not 3 years, maybe 2 years or to stabilize, which is about 3 cycles per year, right? Or 2 or 3 cycles per year. I think it's important to understand that even though the guidelines change, it takes the reviewers a couple of cycles to catch up to the guidelines.
at least a couple of cycles.
Yeah. But in this case, these are center directors who have been the reviewers and people of your set of skills who have done quite nicely in terms of saying, hey, this is not really that important.
Yeah. Well, to Paul, your point, I mean, it's going to be critical that center directors continue to be an important part of the review process. And, we've all encouraged each other to be on each other's, review teams, et cetera, because I do think that corporate memory is going to be key in the review process, especially since everything is changing. I think that sort of shared memory of what things are important will be important in sort of sustaining a consistent review process.
A few months ago, I was talking with Tony Latai, and I asked him specifically what's going to change with the cancer centers, and he said that the process for renewals is going to change and become simpler. Have you seen that happen yet?
I think the new NOFO that is being circulated, and they were taking opinion from the directors and the associate directors of administration, is geared to simplifying. So cutting the number of pages, combining sections. So I think that we are headed in the right direction. If there were to be a site visit, I don't think it's going to be as much kabuki theater as before. I think it's going to be more straightforward. So I'm hopeful that that's the case.
And I agree. I mean, our challenge has always been sort of when, and we hear it all the time. It's like, hey, they cut our page limits down from 12 to 6. And then the reviewers asked us for 14,000 pages of information, right? It's like, okay, but we only have 6 pages to talk about it. So I think the simplification piece has to go hand in hand with what the reviewers are told to expect, right? We can't, if we're going to simplify things, we're, for example, space. We're not going to be able to give you maps of the entire campus that label, where every single shared resource is anymore, right? So I think that that's going to be an important component of the simplification, is that carries down through the program officers, through the review teams, to say, all right, this was not asked for in sort of the new format. So you can't really go and ding them for something that they didn't get asked to provide. So.
And now to put a positive note on all that.
Well, yeah, for renewal, you have to have positive notes.
So yeah. I think as a new director, leading the renewal process, even though it was a little bit bumpy, it really allowed us time to reflect on what we have, our accomplishments, and a time to say, okay, let's gather and say, who are we going to be for each other and for the people of New Mexico in the next 5 years? Yep. And I think, with all the glitches and things that are happening and maybe the extra bureaucratic paperwork that may have gone into renewals in the past, I think it is really an important moment for centers to take stock.
Yeah, it really has brought us closer as a community. Because we all climbed into the lifeboat together, right? And so it really has brought us closer as a community.
Yes.
It's interesting. I can't resist making a smart alecky comment about kabuki theater, because kabuki theater is pretty easy to do, really. You just need the performers and a little face paint. But what I've heard people say, it's more like kind of more degraded from there to Phantom of the Opera, or maybe The Lion King, and the site visit is where the chandelier falls and the puppets come out. So
I think we're going to build that into our next site visit if we actually have it. I'm going to come down in a chandelier. I think that might actually either get us a really good score or a really bad score.
And then the kabuki people will come out and dance on the ashes. But I don't know why I did this. But I just couldn't resist. Since we're all talking about fun things like theater, what about the pay lines?
They're too low. I mean, if you ask any cancer center director and said, "Hey, where are the pay lines?" Everyone would say, "Well, they're not at 80%, so they're too low." I think that the question is, where are they going to be? I mean, again, with the new budget, with the multi-year funding components, where they're going to be. They're certainly better now than 4%, right? Because at 4%. Essentially, you're looking at 5 grants that scored a 1, right? And then how do you pick, of those 5 grants, how do you pick the 2 that are going to be funded? So I think that, if we get back up into the 9% range, I think that's a lot better. I do think that people are worried because of sort of the issues with multi-year funding and how that how that skewed everything. There still everybody's still. I'm certainly still waiting for the other shoe to fall, and that goes back to the uncertainty piece. So I think we want to see it go into operation and see how the year ends up.
Mm-hmm. Yeah.
I agree. I think that the story that we were telling ourselves and that why we were so the uncertainty was keeping us up at night. Was that we were getting a 40% cut, 15% indirects, and then all grants with multi-year funding, right? Upfront funding, and which was going to be devastating to the cancer research community. Thanks to the work of all the advocates and the patients and the ACI, the ACR, ACS, everyone, and including, our directors who went up before the appropriations committee and the community that was built, we are in a much better place. Is it perfect? No, but there is going to be impact. And I think the important thing for us as directors, and you may disagree, Kelvin, is that we need to protect the new investigators.
That's exactly right.
Because we need the continuity, we need the innovation, and we need them to stay here until the pay lines stabilize. There are no pay lines, but
Yoli's entirely correct. I mean, we've always argued that money comes and goes, but if you lose a generation of scientists, young scientists that just leave because they say this is crazy, I'm not doing this, they're gone, right? You can't buy them back. So it's important I think that the greatest impact of the reduced pay lines really was on that next generation scientist and keeping them there. So actually, once the HHS budget passed, like 2 hours later, we sent out a cancer center wide email saying, "Hey, look, some good news," mm-hmm. right? And and primarily aimed at our younger investigators who had been buffeted by years worth of uncertainty and may have are working towards, hey, I'm not doing this anymore. I'm going to go work for Lilly or somebody else. And I'm not going to stay in this. This is just crazy. So we wanted to continue to emphasize that. And I think that's going to be the most important thing of keeping pay lines stable and keeping that funding going is really that next generation of scientists.
Well, what I was also kind of trying to understand and failing miserably is what the world after pay lines or without pay lines being used to determine who gets paid and who doesn't get paid, what that looks like. Because other considerations can come into play, which actually some of them, if they're geographic, you may actually be on benefiting from that. For example, it's so I don't know. How does that? Personally, I'm not worried about Tony Latai being the guy who gets to sign off on this as an administration person. But what about the whole sort of beauty of pay line system was that it didn't matter who was in charge, or at least that was the ideology, that it didn't matter. But where are you on all of that? That kind of where this state of affairs, where the chief executive of the National Cancer Program or National Cancer Institute is the guy who is making the final decision and has to. You can't just say, well, it doesn't matter because the pay line was this. It's a long question. I'm sorry.
No, I think there are very clearly positives and negatives, in that entire discussion. I think it all boils down to fairness, right? I mean, that's what everybody's going to come down to is that was that decision on any particular grant a fair one? And fair is obviously a complex concept, right? what is fair depends on what framework you're using. There are many frameworks that are legitimate, and something might be fair in one framework that's not fair in another framework. Geographic distribution of funding. Some people might consider it fair, other people might consider it unfair. So I think that's the complexity of it. I think in general, sort of as a principle, I don't think that anybody is sort of, oh no, we can't do it that way. We just have to have a number to, a single pay line. I do think it's obviously, that whole it's the devil in the details is like, what is going to be incorporated in that decision? And is that a fair decision? And again, it's a very hard question to answer. And there are probably lots of legitimate answers in that, and which makes it even more complicated.
I agree. I agree that we have, I have confidence that having a physician scientist
Yep.
at the head of the NCI is really going to, champion science and basic and clinical research. So I have, I'm really excited about the possibility that the person who's been making the decisions is really going to be someone who's been in the trenches for his entire career. On the other hand, all institutes have priorities and all funding agencies have priorities, and some funding agencies exert those priorities in addition to the score in their funding decisions. And so I think the NCI, by doing this, may be doing something similar to other institutes, and we should give it some time to play out, to figure out, where we land on that, on one side or the other of that issue.
Mm-hmm. Yeah. Is there anything you can think of that you can't do at this time in 2026 that you could do at this time in 2025? Has anything changed in your daily life? Is there anything that's verboten?
Well, I used to be able to run farther in 2024 than I can now. So that's changed. Okay. Well, I think
that's 24 though, not 20.
Yeah, exactly. I know. I think one of the things that has been more complicated is team science, right? I mean, that's been an area where we've had a lot more. I mean, it's been a very big focus for us at IU Simon, and sort of we've been pushing towards that. But sort of the larger grant mechanisms and the team science things, it's been much less clear how we're going to do that. And in fact, we were talking at Leadership Council yesterday. A group that is renewing its SPOR just found out a month ago that they could renew their SPOR. And so it's like, okay, and now they're going ahead with doing that. But there was a lot of uncertainty for them as to whether or not they were actually going to be allowed to renew it. So I think that's
why not? Why wouldn't it be?
I don't know. I mean, they just weren't getting a clear answer from program. But it was one of those things where there's for us to say, all right, if we want to do team science, what is that going to look like, in this time right now, that we had, again, a lot more certainty a year ago.
But what's the obstacle to team science?
I think that the question is, what's the pay lines going to be? What are the how much funding is there? Whether or not this is a priority. Again, and that's all moving simply because nobody was clear how much money the NIH and NCI was going to have. So if you're going to do that, what do you protect, right? Do you protect the individual grants, or do you protect the larger team science grants? So I think that that's all been part of the mix. And hopefully over the next few months, we'll get more clarity coming out of, sort of that period of uncertainty that we were in.
Yeah, that question is food for thought, actually, because we are putting a lot of our energy into areas that before we didn't have to. I think I've become more of a cheerleader than in my role as director, and one of the things that's been harder for us, and considering we have a very unique population in our state, a beautiful unique population in our state, And therefore the training grants for our students and postdocs, we're serving the unique populations of our state. And the uncertainty there of being able to say, we have a certain amount of training grants that are going to enroll these students, that are going to be from very different backgrounds. That certainty is not there anymore. And so what do you do? So how do you gather resources from other places in order to continue that mission? Because we're not stopping, right? We're not telling students that they can't be graduate students, they can't be postdocs anymore. We're continuing the work. We just have to shift funds from one place to another.
I was more also worried about the community outreach and engagement. Has that become more difficult?
Actually, no.
Cool.
Yeah. So we have, there are challenges. I'm not going to say that there aren't, but for example, we have a uniquely monolingual Spanish navigation program for women to get screened for cervical and breast cancer. And if they have a diagnosis, then they are also navigated to care with an explanation of what clinical trials are so that they also enroll in clinical trials. That's amazing. And that has continued and with support from the Cancer Center. And it's one of our flagship programs. And so that's part of our community outreach engagement with other communities that we serve and groups that we serve has continued, have moved forward. That's a good question. That has not been impacted.
That's very interesting. I was afraid of it, but wouldn't have predicted that.
Mm-hmm.
Well, I mean, so I use very much like, or Indiana is just very much like New Mexico. Our catchment area is the entire state of Indiana. And we are very cognizant that there are rural communities that are being, left behind. So the question is, how do we impact that? How do we actually get out there? One example is that our mobile lung cancer screening unit just got on the road last year and to drive out to all the communities in Indiana. And in fact, the route that they mapped was based on the incidence of lung cancer that our Office of Community Outreach Engagement put together that heat map. So they're just not driving across the state of Indiana randomly. They're actually hitting all the counties that have the highest rate of lung cancer. That was a critical component of our Office of Community Outreach and Engagement to do that. And over the last year, I think we've had a 75% increase in lung cancer screening. Part of it is the mobile unit, but part of it is now that mobile unit also brings awareness to, all our hospitals and clinics that we should be doing that. So that was, if they can't come to us, we need to be able to get out to them. And that's not only screening, but that's also clinical trials, right? I mean, we need to be able to do clinical trials, design clinical trials that can be done out in the community. And we're not talking about taking a complicated trial and say, hey, let's just dummy this down and put it out in a community hospital. We're designing a clinical trial that impacts the people that are out there, for example, lung cancer prevention. And how do we design that trial so it can be actually implemented in a primary care setting or, a secondary hospital, critical access hospital, so patients can actually get out there? How do we move technology out there, right? Remote sensing, all those other things. So that's an important piece. And that's very much tied into community outreach and engagement.
Mm-hmm. What about, I guess, are people reticent to come to the Cancer Center right now or to travel, to walk out the door? Or
I would say that, you talk to every Cancer Center director, what's the number one complaint you hear? Parking stinks at your center. So that's the,
That's a very... You're going in the wrong direction.
No,
but
yeah,
it's okay. But it's funny. It's funny.
I do think that people, I don't think they're reticent to come, but again, everybody's traveling from the entire state of Indiana to come. So and again, our goal is to treat people where they live and give them the same quality of care. If you walked into University Hospital, that's the same quality of care that you'd get if you walked into Ball Memorial Hospital out in Muncie. So that's a key piece. And then the access to clinical trials is the same. But I'll flip it and say that, for example, in the CAR T cell field. Right? So CAR T cells, our university hospital, our inpatient is actually full of patients getting CAR T cells, right? And good, because it's great therapy. The issue is that CAR T cells that we're treating are small volume, are small number diseases, right? Myeloma, lymphoma. And we've already filled up our hospital. So I've always said to our healthcare system, can you imagine what will happen if a breast cancer CAR T cell hits? We will not have the space at University Hospital to take care of those patients. So the answer is we need to be able to move this out to the regions, to the regional hospitals, other hospitals, and we need to be able to move it out to outpatient. So we need to be able to plan for those things now and do that. So it's not just, hey, we want patients coming down to a university hospital. We will will need to move all that complex care out into the regions and into our regional hospitals.
Wow.
So I understand the question that, people being afraid of seeking care. And I think that just like during COVID, we're going to find some cancers that were more advanced when they're found because of that. And also, people seeking care elsewhere. And it's a challenge right now. But this is why we also have the community outreach and engagement and navigators to try and navigate patients and if whether they're pediatric or adult to care into the cancer center or the pediatric.
How much can you help somebody who may have issues with documents or potentially issues with documents? Is there a way to help? Because that's not your battle. Your battle is cancer. Right.
Our battle is cancer. Is treating cancer. We do have a partnership for health for screening and prevention with the consulate, the Mexican consulate, and the Mexican consul is on our community advisory board. And we have a lot of education in Spanish as well. Spanish-speaking oncologists who educate about prevention and screening and care. So we're doing that. But you're right. One of my leaders said that to me. Just remember, he said, your enemy's cancer, right?
Right. What about Medicaid? How is that affecting you?
So I just got the numbers for the end of January. So we go between 13 and 14% of our patients being covered by Medicaid. But the state is a high adopter of Medicaid, which is more over 40% of the state are on Medicaid. So we did the back of the envelope calculation of how the impact of losing coverage for our patients. Right now we have about almost 7% indigent, uninsured, uncompensated care. So that number is going to go up, but it's not going to be catastrophic just because of our payer mix.
I would love to see those numbers eventually if you ever are willing to, or if you wanted to write about that as a guest editorial, either or both of you. That would be fascinating because I'd love to see those numbers. I think a lot of people would love to see those numbers, the impact of Medicaid. And I know it's not a conversation for the directors.
And I think that those are still ongoing conversations. I mean, I think the state of Indiana is looking at a $2 billion decrease in Medicaid funding overall. And then the question is, how does that impact the healthcare systems? I know that our healthcare system, iHealth, has been, very actively sort of modeling a lot of things. I don't think that they have come to any, sort of clear conclusions as to what they want to do, but they are very actively thinking about that.
The numbers for the state are daunting. yes,
Yeah.
for the state of New Mexico and the health system are daunting. And there has been a lot of planning, a lot of strategizing on how to mitigate that. Yeah.
Wow. Yeah, I can't. I would love to see that and focus on it and do an actual story on it, or even return to the directors with that subject alone, if you want.
Yep.
We
Yep.
can do the exact same thing again on just that. Meanwhile, is there anything I forgot to ask? Anything you'd like to talk about?
I think, to Yoli's point, I mean, that our battle is with cancer, and that has never changed. I mean, and we tell our cancer center, despite all the sort of turmoil that we've gone through, we still have lives to save, and we still have those lives to save. So I think that one of the questions has always been, how do we become more resilient? What are new ways to improve what we can do? I think that for us, certainly partnerships with pharma have really come more front and center. I think that there has been and I think this is driven at a number of different levels. Certainly on the pharma side, with the new requirements of a certain percentage of their patients on, their pivotal registration trials have to be from the United States, has really sort of put into their minds, how do we enhance clinical trial networks? And how do we, grow the ones that are coming out of the cancer centers? So there have been a lot more partnerships and a lot more engagement in that sense. And I think that's good for everybody. I think it's good for pharma. I think it's good for the cancer centers. I think it's good for us thinking about what the right mixes are. I think it's also good for us plugging into how do we actually take our science and move it into our patients. So it really supercharges the translational pipeline. It makes us think more of sort of that development of intellectual property, something that IU has not really done a lot of until recently. But I think that all blends into the idea of how do we diversify what we do to be more resilient, and not sort of all be dependent, for example, on NIH funding for everything. How do we grow that diversification? But I do think that diversification is an important thing. I mean, our evolutionary biologists have said that even, in systems that don't have a single human being in it, diverse ecosystems are more robust than non-diverse ecosystems. And so that is a biological fact, and I think that's an organizational fact.
Yeah, I think that one of the things that we have to really be aware of is that no matter what happens in the next 5 years, we're not going back, right?
Yep.
We're not going back to the way we used to do things. We're not going back to the way to the processes that we were used to. And so that presents both a challenge and an opportunity, right? The challenge is we need to grow to meet the needs of New Mexicans for their cancer prevention, diagnosis, and care. We need to find an innovative and more effective way to translate discoveries into the clinic, and the discoveries that are going to impact the people that we serve, both locally and globally. So it's and Kelvin said that. So where do we put our resources? What is that new way of doing things? So one way to fill that valley of death of early phase investigator initiated trials is that we started a pilot program to fund those specific trials. Now they have to go through a process. They have to be reviewed. They have to have a protocol writer. They have to have, a pilot to show feasibility. But then we fund those first two studies as proof of concept that we can do it, right? And then pharma will say, yes, I want to partner with you because you've got the process all worked out. So I think it's important that we decide, and put in not in isolation. I think the Cancer Center Directors Group is amazing. How do we move forward in a more efficient way? How do we grow? Because we need to provide access. And for that, access to clinical trials, access to basic research, to education, to patient care. And that's the $64 million question.
And I'll emphasize, and I'll make a shameless plug. So the Hoosiers actually are national champions in football, right?
Yeah.
And 2 years ago, the president of IU said, we're going to become a football school. Right? This was when IU had absolutely the worst record in college football. And she said, we're going to become a college football. We're going to be a football school. And in 2 years, they have actually done that. And if you asked anybody 2 years ago, how that's crazy. What do you think about that? And everybody would have said, that's impossible. But I think what we have all taken away from certainly here in Indiana is that it's not impossible. That if you are innovative, if you are clever, if you pay attention to details, if you have a clear vision of what you want to do, and then you can find the resources to do it, nothing's impossible. Mm-hmm. So all of us are wearing our national champion shirts, not because we're very proud of being national champions, but it reminds us that nothing's impossible. And the Indiana Hoosiers are a perfect example that nothing is impossible.
And again, so one of the things that is different about New Mexico is that we have incredible support from the state. Support for our cancer center is written into law, right? And it's recurring. And so, and they call us their cancer center. The legislators call our cancer center their home. And so, and they come and have meetings here and they invite us over to the Roundhouse. So I think that looking for that diversity of portfolio of support for that innovative approach to increase, to reduce the burden of cancer in our catchment area.
That's fantastic. And yeah, this is an exciting time filled with uncertainty, but also opportunities.
Yes, exactly.
Thank you so much for agreeing to talk to me about all of this.
Thank you for having us.
Thank you for having us.
Thank you.